Welcome everyone to the final series of the complications of epidural and treatment options. We will begin by talking about indications and contraindications for epidurals. Some of the indications are treatment for labor pain. This also includes early labor, vaginal delivery of twin infants and preterm infants. Epidurals can help facilitate blood pressure control, especially in pre-eclamptic women. It also blunts the hemodynamic changes during uterine contraction and aid with deliveries. Some of the absolute contraindications are patient refusal, especially the inability for the patient to cooperate during the placement, increased intracranial pressure due to mass lesions, infection at site. It's always important for us to look at the site prior to placing epidural. We don't want to track any viral or bacterial agent into your nervous system via the cerebrospinal fluid. Uncorrected maternal hypovolemia, for example, you have hemorrhage. If the hypovolemia is uncorrected, this can lead to severe hypotension, which can be detrimental to the mother and the fetus as well. Inexperienced providers and inadequate resources are also contraindications. If you do not know how to place an epidural or anything about an epidural, it is not recommended you place one on a patient. Common complications that patients may face after or during an epidural placement can be hypotension. It is always recommended patients refuse a fluid bolus prior to the start of epidural placements, and the provider should also look at the starting blood pressure and the blood pressure after the bolus test dose has been given. Post-dural puncture headaches as well can occur. Benson will talk more about post-dural puncture headaches in later slides. Epidural hematoma formation. This is a medical emergency, so a neurologist or a neurosurgeon needs to be consulted immediately because this can cause some severe mortality and comorbidity to the patient. Urinary retention can occur. This is why urinary catheters are placed in the females after epidural because they will have difficulties urinating. You can have a field block. For example, the patient's left side will be numb and the other side, they'll be able to feel the contractions. So a way for us to help with this field block can have the patient lay on the side that is not numb or is not receiving any anesthetic or analgesic properties to that side, and then the patient can be bolus roughly 5 to 10 mL of whatever local anesthetic is being used. If this doesn't work, it is recommended that the catheter be replaced, the epidural catheter be replaced. Patients can also experience back pain at the site of the epidural placement. There's also the risk for infection. That's why it's highly encouraged for the septic technique to be used at all times. Patient can experience transient neurological syndrome, which is back pain radiating to legs. This normally occurs with lidocaine administration. We usually don't use lidocaine except for emergency C-sections. That's when we use the 1 to 200,000 lidocaine. We use a 2% lidocaine, 1 to 200,000 of epi during emergency C-sections. But normally lidocaine would not be used due to this reason. So let's talk a little bit more about high spinals. High spinals normally occur when you have unintentional intrathecal administration of epidural medication as a result of a dural puncture. A catheter migration might also cause this complication. So you can also have a high spinal when you actually give an epidural bolus. If you give an epidural bolus or an epidural dose in the intrathecal space. So if this occurs, you want to do left uterine displacement. You want to continue administering fluids and vasopressors to achieve hemodynamic stability. You want to avoid a reverse transdural position because this does not spread cephalad spread So we will start by explaining high spinals, which is the unintentional intrathecal administration of epidural medication as a result of dural puncture or catheter migration. These are all a result in this complication. So you can also get a high spinal if an epidural dose of a bolus is administered intrathecally. If a high spinal occurs, you want to do left uterine displacement. So lifting the patient. So we will start by talking about high spinals. High spinals is due to the unintentional intrathecal administration of epidural medication as a result of dural puncture or catheter migration. So you, in layman's term, you're basically giving an epidural bolus or dose in the intrathecal space. So when this occurs, you want to do a left uterine displacement. You want to continue administering fluids and vasopressors so you can achieve hemodynamic stability. You want to avoid the reverse Trendelenburg position. This does not prevent cephalad spread. It may cause cardiovascular collapse because of venous pulling related to sympathectomy. You also want to rapidly control the patient's airway and hemodynamics. You might want to intubate the patient to ensure oxygenation without aspiration. And as mentioned earlier, continue fluid administration and give vasopressors as needed. So ways to rule out high spinals. So you want to determine patient's normal complaint of difficulties breathing during cesarean section delivery under local anesthesia. So sometimes the high spinals can be due to an inability to feel themselves breathe because the abdominal and thoracic segments are anesthetized. So some maneuvers to rule out high spinal is to determine the patient's ability to phonate. So you can ask them to pronounce some certain words. You can also determine the ability of the patient to squeeze your hand, and this will help determine the block level. And that will help determine if the high spinal is up to the brachial plexus, which the brachial plexus is in C6 to T1. So if the patient is unable to squeeze your hand, unable to phonate, that could determine that you have a high spinal. So hypotension occurs due to vasodilation of the arteries and veins. You have a reduction in venous return, cardiac output, and blood pressure. So prior to starting an epidural, you want to do a bolus of 15 mL per kilogram. And some of the vasopressors that you can use are ephedrine and phenylephrine. Making sure they are appropriately diluted prior to giving the patient is very important as well. So treatment for low blood pressure, you have ephedrine. You have the IV dose is 1 to 10, can be 5 to 10 milligrams. So you can dilute it in 5 or 10 ml syringes. Most vials come as 50 milligrams. If you dilute it in a 5 cc syringe, you get 10 milligrams per ml. If you dilute in a 10 ml syringe, you get 5 milligrams per ml. Patients can also receive 25 to 50 milligrams. So you can actually give 25 milligrams IM, and then you can give boluses 5 to 10 milligrams IV. So you also have niacin or phenylephrine. You can give 50 to 200 mics IV increment bolus. You also have adrenaline, also known as epinephrine. You can dilute it in 1 milligram in a 250 cc bag, which will give you 4 mics per ml. And then you can have it ongoing at 1 to 16 mics per minute. You can have noradrenaline, which is also norepinephrine. You can do a dilution of 4 milligram in a 250 ml bag, which gives you 16 mics per cc or 60 mics per ml. You can do 8 milligrams in 250 bag, which will give you 32 mics per ml or 32 mics per cc. The dose can be 1 to 30 mics per minute. So we will look at a postural puncture headache. Postural puncture headache is caused by a decrease in your cerebrospinal fluid in the subarachnoid space through a leak on the dura. You have a loss of hydraulic support. The medulla and the brainstem drop into foramen magnum. This causes stretching of the meninges and pulling of the tentorium. And the patient can experience headaches with movement or when they're sitting upright. So this slide explains like the incidence of postural puncture headaches. And increased incidence occur if you use a large non-pencil point needle or a cotton needle. If you have multiple punctures, the female gender, the patient's age, younger patients are more likely to experience postural puncture headaches. And if a patient's already had a history of postural puncture headaches, if you use air for loss of resistance. You have a decreased incidence of postural puncture headaches with using a pencil point needle and a smaller diameter needle. If you have a single dural puncture, using fluids for loss of resistance, an older patient, male and non-pregnant. Some of the features for diagnosing postural puncture headaches are determine how long it has been since you've placed the epidural. Normally, a postural puncture headache occurs within several hours to the first and second post-op days. Patient might have mild to moderate bilateral frontal headache. The frontal headache can radiate behind the eyes and across the head in the occiput. This headache is very positional. So when the patient is upright, they might experience the headache and experience relief when they lay down. They might also experience nausea, vomiting, photophobia, loss of appetite, vertigo, loss of hearing acuity, and ringing in their ears. Benson will currently take over the next session of the slides.
Welcome again to this last and final part of our presentation, which I'll be focusing on treatment of postural puncture headache. As I earlier said, postural puncture headache sometimes arises as a result of the fact that we use our big epidural needle and for some reason it mistakenly puncture the dura mater. And when that happens, CSF starts leaking out. And as the CSF is leaking out, it is putting a lot of tension on the meninges. So consequently, the patient is going to present with a lot of headache afterwards. However, often we envisage that this treatment is supposed to, that the headache should resolve within 10 days. And part of the treatment is making sure that the patient is is well hydrated. Lying down seems to relieve the headache more than sitting up. When you sit up, the pressure or the traction on the meninges are more than when you lie down. Oral analgesics like Tylenol, paracetamol have been found to be very useful in the treatment. We can give caffeine, what we call Cafegod sometime. Some people can just take a cup of coffee, or we can give Cafegod. I think about 2.5 milligrams of Cafegod for some have been found to be part of the treatment of postural puncture headache. Theophylline, gabapentin, steroids have also been used, and they have been found to be effective in the management of postdural puncture headaches. In the worst part, if all of these have been tried and nothing is working out, we might end up doing an epidural blood patch, which is a definitive treatment for resolving this headache. When we do an epidural blood patch, what is it that we want to achieve? It is simply, we are trying to seal that area of the dural matter where we punctured, where the CSF is leaking out as a result of the fact that the blood that we are going to push into that space is going to tamponate that very area and stop the CSF from continuing to leak out. And the most part, it has been found to be 90% effective. And most patients always express feeling better after an epidural blood patch. So in this slide, we're going to just see like, what are the steps? What do we do? What does it take to do an epidural blood patch? First, for you to do an epidural blood patch, you need to explain the procedure to the patient and get their consent as usual. So it's a very, very highly sterile procedure, just the same like when you are placing an epidural. So you prep and drape patients back, and get an IV site in an aseptic manner. So because we are going to be drawing blood from the patient's arm or somewhere, we need to make sure that that area is aseptically dressed to ensure that we don't contaminate that blood before we send it into the patient's suprarhinal space or epidural space. We make incision at the site below or at the level of the lowest initial needle incision, which means that if this puncture was done, if we give our epidural at the level of L3, L4, for instance, and we come back to do an epidural blood patch, we will go either at L4, L5, or we go at L2, L3. So that's exactly just what that sentence means. We go a step above or a step below where we did our previous epidural. So we draw 20 mils, approximately 20 mils of venous blood is drawn from the vein and slowly injected through the epidural needle into the epidural space. So this procedure generally involves two persons. I think the moment another person is dressed sterilely ready to pull the blood whenever it's ready, and another person, as you are giving your epidural, once you look at the epidural space, another person is already ready to draw the blood immediately and then hand to you in a very sterile way, so that everything is done sterilely. We remove the blood and we don't contaminate, we don't let it sitting down for any reasons before we inject into the epidural space. Once that is done, we give about 12 to 15 mils is sufficient to block that area. And once that is done, the patient remains supine for 30 minutes to 1 hour before ambulation. This ensures that that area, that we put pressure, that blood put enough pressure at on that spot where CSF is leaking. Actually, it is said that this procedure can be repeated every 24 hours, repeated in 24 hours if the patient doesn't feel better or if we think that we were unsuccessful. All right, some of this, yeah. So it depends on how the patient responds to, but hopefully we do it so well, and most of the time the patients always feel much better. This second slide is talking about epidural hematoma, which, as earlier said, it's an emergency because it means that for some reasons we have blood, continuous blood leaking around our epidural space and accumulating around that space. So it's a big leak, big blood leak, maybe from rupture of a blood vessel or something. And this goes back to the reason why we always want to make sure that we have adequate coagulation profile before we set an epidural. That means that we must have, our platelets must be at least 100,000 and above in most parts, and patient is not on any anticoagulants and stuff like that before we consent for an epidural. So this is caused by accumulation of blood between the dura and the bones. And it's characterized by severe backache. The patient might present with some neurological deficits. The patient will have bladder or bowel dysfunctions, spinal area tenderness, unexplained fever, and then this needs to be decompressed within 8 hours. So we can see that immediately you develop an epidural hematoma, the scenario of everything just changes. The patient, the backache will be so severe that you can't explain why. The patient might not be able to lift up their legs. They start presenting with bladder and the bowel dysfunction. Sometimes they might not be able to know when they are urinating and stuff like that. And so you have to keep your high index of suspicions. You have to be highly, highly suspicious that there is something serious going on. And in more advanced system, if you start suspecting that you have like an epidural hematoma, first you have to go back and recheck what was your coagulation profile looking like. And then you might want to get like a CT of the back to see exactly what is going on there. And then you consult a neurologist and a neurosurgeon for possible decompression. Local anesthetic systemic toxicity is one of the complications that arises whenever each time we are placing an epidural. Just the same like when we do a spinal, we have to be very watchful for this. And this occurs with accidental intravascular injection of our local anesthetic agent or rapid absorption. So you might still not generally be inside a vessel, but for some reason, the blood vessel around the space becomes so highly dilated, vasodilated, that there is rapid absorption into the system. And once you have rapid absorption into the system, in the most part, you will present with signs of toxicity. So there are some steps you can take to minimize that effect. And one of them will be to always make sure that you do a test dose. A test dose is done by administering 3 mL of our local anesthetic agent, our lidocaine, for instance, that comes with epi when we do our epidural. Some people do 3 mL, and if everything is fine, then they go ahead and finish the remaining 2 mL, because remember that the lido comes in a 5 mL ampoule, and then you draw it up in a 5 cc syringe. So you aspirate prior to administration of the dose and note signs of blood. If at all you don't have any blood inside or any CSF coming back, we assume that we are not in the intravascular space. Sometime then, remember again that you can have that problem coming from rapid absorption. So that's why we give it in divided doses. You cannot just give 5 mL straight. So as part of the way to minimize the effect, 3 mL administering, if you see any signs like increase in the heart rate, your blood pressure is going up, the patient is presenting with some type of maybe beta test in their mouth and the legs getting very heavy, then you start thinking that you might be having signs of systemic toxicity, or they might develop things like seizures, they might develop things like restlessness, agitation. All of those are signs of systemic toxicity of local anesthetic agent that we have to watch for. So we monitor our vital signs, and treatment of all of this is supportive. Once we think that we have developed a systemic toxicity, vital signs becomes very important. We give a lot of fluids. In some places, they have lipids agents that you can administer to be able to, which helps to treat local anesthetic toxicity. I'm sure that in the next slide we're going to be talking about that. Give oxygen. We secure airways, always very important. If you think that something serious going on, the first thing is that give the patient oxygen and try to secure that airway before things get worse. And we continue our resuscitative efforts. This is just kind of summarizing, like, what are the signs and symptoms of local anesthetic toxicity. You see that it starts right from down, from the least to the most grievous sign. So it starts with patient will start telling you, I'm feeling drowsy. I don't know how I'm feeling like. I feel like I'm going to throw up. I feel like I can't talk. Once you start hearing this type of sentence, this type of words coming from the patient, it needs to drive you to start anticipating and proactively intervening. Paresthesias in mouth and tongue, tinnitus, auditory hallucinations, and ringing ears, and patient will be able to tell you all of this stuff before things go out of control. Then you have muscular spasms. Then in the most part, some patients present with seizures. So you can see that most of the time, the neurological signs and symptoms always come before your respiratory, and the last one, the worst part, is the cardiac. So if you intervene faster, you can stop or you can curtail those complications from going to the level of the respiratory arrest or cardiac arrest. That's why you have to be very, very vigilant and keep connection, keep talking to the patient throughout this phase of the process. So this last protocol is coming from ASRA, which is American Society of Regional Anesthesia. This is a protocol that I've adopted on how you can adequately and efficiently treat complications or local anesthetic toxicity. So you should be able to differentiate what is going on from other causes of cardiac arrest. For you to be effectively treat problems of local anesthetic toxicity, you need to be sure that what the patient is presenting with is not coming from other causes, because otherwise you will miss the important part of this treatment. As usual, you cannot do all alone. You need someone for help. You focus attention first on airway management. If it's a patient that was easy to intubate or whatever, you start oxygenating and immediately you try to intubate that patient. Seizure suppression, benzodiazepines are preferred. Avoid propofol. Patient having signs of cardiovascular instability, in the most part, they will always alert the nearest facility having cardiopulmonary bypass capabilities. I feel like at this point, it is like if you try to intervene and things are not working out, and you feel that the situation has become so grievous that you will not be able to manage in a small place, then you might need to maybe push up the interventions. You might need to transfer the patient to a different facility or something. But in the most part, if you have enough help and you have enough equipment, you have enough resources, you should be able to intervene and solve this problem. You manage your cardiac arrhythmias depending on what you see on your monitors, depending on what the presentation is looking like. If the patient is in AFib, if they are in SVTs and or whatnot, you have to integrate your ACLS protocols into this management as fast as possible. And you adjust your medications and perhaps prolong effort. Avoid vasopressin, calcium channel blockers, beta blockers, or local anesthetics. Again, we know here that these patients, when you have local anesthetic toxicity from local anesthetic agent, most of like calcium channel blockers and the beta blockers, what they do is that they're going to cause severe hypotension, which is going to superimpose on what you're already suffering with, because when you have this scenario going on, in the most part, these patients are going to be hypertensive. So you're trying to avoid anything that's going to make the scenario worst. You reduce your epinephrine dose to less than 1 mic per kilo. I think I already told you guys how you can effectively dilute your epinephrine. Either you have a constant 16 micrograms per mil concentration or 32, depending on how you dilute it. Then we have the lipid emulsion, which I kind of signaled in the previous slide. That has been found as similarly like a standard. You need to have lipid emulsions normally before you give an epidural or a spinal. I know that in our system here in Cameroon, it might be a little bit, it might be rare, but that's what the standard says. And I'm sure that As times go by, a lot of facilities will start being able to equip their pharmacy with these lipid emulsions, which is 20%. 20% means you're going to be giving that's 200 milligrams per meal. You bolus with 1.5 mils per kilogram, and then you can set up a continuous infusion of 0.25 mils per kilogram per minute. You can always repeat your boluses once or twice for persistent cardiovascular collapse. So if you do what you are doing, thinking that you are doing things right and hypertension is persisting, you can always repeat it. You keep repeating until you get good effect. Double the infusion rate from 0.25 to 0.5. So if you do the same thing 2 times and it's not going, you have to change the strategy. You have to scale it up. You move from 0.25 to 0.5 mils per kilogram per minute. Continue infusion for at least 10 minutes after attaining circulatory stability. Recommend upper limits. Approximately 10 mils per kilogram is the upper limit for infusing. So you see that you start with 0.25, you still have a lot by which you can go to until you reach 10 mils per kilogram. And you infuse over 30 minutes. And in the most part, this always makes things better. It's an effective treatment. So what are some of the considerations after placing an epidural? 1, only anesthetists allowed to bolus epidural. I know that in some places, you might tend to convey this responsibility to the hands of nurses. I've seen that sometime when I practiced in Cameroon some years ago, but that is not standard, that is not right. You alone have the right to bolus that epidural. So if you were to administer an epidural, you place an epidural, and you come maybe after 60 minutes or after 90 minutes to bolus it, you are the one to come back, check your vital signs, check the level of your block, and then you bolus your epidural. Don't convey that responsibility to the hand of a registered nurse or whoever, because they have not been trained on this. And if they have been trained, we know that there is risk of catheter migration and all of that. So we always want to make sure that we exclude all chances of complications that can arise from our epidural. As usual, always do a test dose to verify correct placement and ensure that the catheter hasn't migrated. Patient must be reassessed before and after a bolus dose is given. Very important. Patients are advised to stay in bed due to decrease in sensory and possible motor coverage. So I know that some patients will want to ambulate around. That is not a good practice per se, because if you have a higher block, maybe blocking your motor and all of that, the patient can easily fall down, and that might be a little bit more catastrophic. So it is advisable that once you place an epidural, that patient should lie still in bed. As always, patient will need a Foley catheter. Remember that one of the complications that you can have is urinary retention, but with a Foley, things should be okay. And one of the advantages that we know is that when we have an epidural, if things were to go downhill, we can easily convert our epidural into our anesthetic technique to be utilized for our cesarean section. And that was the last slide. Wish to take time to finally say a big thank you for hanging in with us all this while through all these different recordings. We are still going to post again 1 or 2 videos on how we actively place this on a live patient and on a mannequin. And there should be another video on how we dilute our local anesthetic agents, showing you how we dilute it, how we draw them up, and how we administer them. Those ones will be the last videos that you will be receiving from us. And again, thank you guys so much for hanging in there with us, and we're looking forward to the final steps of this project. Thank you again so much.